Hello everybody, I'm Dr. Suchard, and in this video we'll be discussing the use of intravenous lipid emulsion as an antidotal treatment, primarily for local anesthetic toxicity. This content corresponds with the Antidotes in Depth chapter A23 in Goldfrank's Toxicologic Emergencies. The learning objectives are that you'll be able to name at least two of the proposed mechanisms whereby IV lipid emulsion has an antidotal effect in local anesthetic toxicity, and to outline a dosing regimen for it when used for this indication. There's an interesting history behind this therapy. It was found by chance that experimental rats anesthetized with propofol were resistant to bupivacaine-induced cardiotoxicity. And if you're trying, as the investigators were, to model bupivacaine-induced cardiotoxicity and you want to get a cardiotoxic effect, this is kind of weird. I mean, a goal of any animal model experiment so that we can begin to apply the results to human therapy, is that the animal model will be predictable and reliable. The variable that had changed is that these rats were anesthetized with propofol instead of with other anesthetic drugs. Propofol is a very lipid-soluble drug and is therefore formulated in a lipid emulsion. As I just mentioned, these investigators were working on an animal model of LAST, local anesthetic systemic toxicity, which is an uncommon but serious complication of local anesthetic nerve blocks. So imagine a patient with a chronic pain syndrome visiting their pain management anesthesiologist to get a nerve block. The figure in the upper left here is showing some various angles of attack to insert the needle to perform such a block. It's believed that, occasionally and inadvertently, the local anesthetic is injected directly into a blood vessel, resulting in systemic effects which might cause severe CNS and cardiac toxicity. Next, we're going to watch a minute-and-a-half video demonstrating how these investigators turned this chance finding into a lipid emulsion rescue therapy for local anesthetic toxicity in rats.
The animal initially has a rapid heart rate and strong developed blood pressure. Upon an intravenous bolus of bupivacaine, the heart rapidly stops beating. We then begin chest compressions to attempt to resuscitate the animal. Concurrently, we begin an intravenous infusion of a lipid emulsion. After just 1 minute, the heart begins beating independently, with chest compressions to help distribute the lipid emulsion. After 2 minutes, the beating continues to improve. Within minutes of lipid emulsion treatment, rapid heart rate and high developed pressure is observed, indicating a strong return to independent beating and circulation.
This was first reported in 1998 in the journal Anesthesiology in this paper, Pre-treatment or resuscitation with a lipid infusion shifts the dose response to bupivacaine-induced asystole in rats. The first author of this paper is an anesthesiologist named Guy Weinberg, and a few years later, in 2006, the first successful human case report of such lipid rescue therapy was published, and Dr. Weinberg started the lipidrescue.org website, both to publicize the method and also to gather data from clinicians using IV lipid emulsion as an antidote. While we have pretty good evidence that the lipid emulsion works, the mechanism of action is not clearly understood. 3 theories exist. The first is that lipid emulsion modulates and enhances intracellular metabolism, which had been impaired by the cardiotoxic drug overdose. There are multiple sub-mechanisms by which this might occur, and our understanding seems kind of hand-wavy to me. Another potential mechanism is that the lipids activate ion channels that had been impaired, and this line of thinking appears to have the smallest amount of supportive evidence. And the third potential mechanism that feels the most elegant and understandable is the creation of a lipid sink. Sometimes this is called a lipid sponge or a lipid conduit, but regardless of the name, it relies on the toxic drug's lipid solubility. The patient is given an IV lipid emulsion, and now the amount of fat in the intravascular space has been increased. The lipid emulsion will bind up the local anesthetic in the blood vessels and will start to pull local anesthetic out of the brain and the heart, redistributing it back into the intravascular space because it's a lipid sink. The lipid emulsion effectively reduces the volume of distribution of the local anesthetic, keeping more of it in the blood and out of the organs where it's causing life-threatening toxicity. How is IV lipid emulsion dosed, per the Goldfrank chapter? The patient is given an IV bolus of 1.5 milliliters per kilogram of 20% lipid emulsion, which is the most common concentration available. Repeat boluses may be indicated, depending on the response, with a maximum of up to 10 mils per kilogram. Some sources then recommend starting an infusion of 0.25 milliliters per kilogram per minute. Keep in mind, though, that the ideal dosing is not known. This is not FDA approved, like that should stop us, but most published recommendations follow similar guidelines. Local anesthetic systemic toxicity is a low likelihood but high consequence event. It's almost exclusive to a few specialties frequently injecting local anesthetics, and even then it'll be rare. But if you're working in a higher risk environment, it'd be nice to have everything you need close at hand. The Lipid Rescue site has protocol cards that you can print out, laminate, and keep with a kit that includes lipid emulsion, and some examples created in 2007 are shown here. Here's a more recent similar set of recommendations put out by the American Society for Regional Anesthesia and Pain Medicine that I also found on the Lipid Rescue website. We see that the bolus dose is 1.5 mils per kilogram, the follow-up continuous infusion is 0.25 mils per kilogram per minute, and they also remind you to report what happened, whether lipid emulsion worked or not, to the Lipid Rescue website and/or another registry. It'd be impossible to conduct any kind of controlled prospective human study, so registries like these may be the best option to collect data. And with the remaining space on this slide, I'm going to show this mnemonic flashcard to remind you of the spectrum of signs and symptoms from local anesthetic toxicity, with the fat-containing strip of bacon here representing that lipid emulsion is the antidotal treatment for severe systemic toxicity. IV lipid emulsion rescue therapy has also been used in cases of serious cardiotoxicity from non-local anesthetic drugs. These uses include beta-adrenergic blockers, calcium channel blockers, antidepressants, particularly the tricyclic antidepressants, and some antipsychotic drugs, among others. The theory here is that we can manipulate the volume of distribution of any highly fat-soluble cardiotoxic drug by giving the patient IV lipid emulsion to redistribute the drug out of the heart and into the vasculature, and maybe take advantage also of improved intracellular metabolic effects. The evidence for efficacy here is weak. So weak, in fact, that the authors of the chapter in Goldfrank recommend maximizing all other resuscitation options before resorting to IV lipid emulsion. And that's all I've got for lipid emulsion therapy. I'll be seeing you around.